Good afternoon, everybody. On behalf of the Institute, I welcome you all for the Dr. L.K. Bhutani Oration. And to begin the proceedings, I request esteemed Director Dr. Srinivas, Dean Academics Dr. K.K. Verma, and our orator for the day, Dr. Siba Raychaudhari, to grace the dais, please. May I request our Director and Dean to welcome our orator, Dr. Siba Raychaudhari. Thank you, sir. I now request Professor K.K. Verma, Dean Academics, to introduce the oration as well as our orator for the day. Thank you.
Thank you. Honorable Director Dr. Srinivas, the orator of today's oration, Dr. Siba Raychaudhari, Madam Bhutani, once again. I miss Dr. G.P. Talwar. He was walking in when I was speaking, so I did not notice. Sir, a very warm welcome to you, distinguished members of the faculty, delegates, ladies and gentlemen. It's my honor and privilege to welcome you all to today's oration, which is Dr. L.K. Bhutani Oration. Dr. Bhutani Oration was instituted in the name of late Professor Dr. L.K. Bhutani. And the award is given to one of the eminent Indian scientists who has been working in India or abroad. You know, the people of our generation who has been taught by Dr. Bhutani and who has been mentored by Dr. Bhutani do not require the introduction, but after that a long gap has happened. So several of you who are present today may not be knowing who Dr. Bhutani was. Dr. Bhutani was one of the most legendary dermatologists which this country has produced till date. He was a person who came here after doing his basic, the MBBS training in Amritsar, and came to Delhi and specifically to All India Institute of Medical Sciences to join internal medicine. And to be more specific, he wanted to be a cardiologist. But soon after coming to AIIMS, he came under the influence of Professor K.C. Kandari, who was his teacher and mentor back in Amritsar also. And the influence was so great and enormous that he landed up in dermatology. And after that, there was no looking back. He climbed almost every peak in dermatology and did all that he wanted to do. Despite not being interested in the beginning to join dermatology, he took the dermatology to the highest level. He headed the Department of Dermatology for over 20 years, soon after Dr. K.C. Kandari retired. And then he superannuated as the dean and the director of the institute in 1996, when we were quite young faculty members. I think I was assistant professor at that time. When he superannuated, I just became the associate professor. And I had such a profound, privilege of being, taught by him, mentored by him, and most importantly, we learned the etiquettes, the dressing sense, how to speak English, how to conduct yourself in the social atmosphere or in the academic events, or any time when you are away from, say, the institution or from the department. These are the qualities which you can never, say, get from the books, or nobody can teach you. You will have to live this to acquire that. He also became the president of Indian Association of Dermatologists, and probably he was the first one to have the fellowship of Royal College of Physicians of Edinburgh in 87. He traveled across the globe. He was a very frequent traveler, and he loved traveling not only by flights, but he will, if the opportunity is there, he will travel in a bus also. For the academics, to promote dermatology, to contribute and share the knowledge of dermatology, and he held the country's flag of dermatology abroad, all the times and every time. He brought the International Congress of Dermatology for the first time in 1994 to India, and that was a very proud moment for all of us. He was the visiting professor at the Mayo Clinic, and then later he headed the department, and he was the professor at King Faisal University in Saudi Arabia. He was a prolific researcher and writer that we know, and he described conditions which were not known at that time are still remembered by his name. And he built a very, say, strong and formidable collaboration with pathologists and immunologists, not only in the institution, but across the country in different areas like leprosy, pigmentary disorders, sexually transmitted infections. And then, of course, he wrote a very popular atlas of dermatology and STIs, which are still very sought after by all the trainees and specifically the postgraduates. So for the oration, we invite, again, an intellectual of very high order. And the previous orators have been, say, like Dr. Jain Pandey, Dr. J.S. Goleria, and there are many others. And today we have a person of similar caliber who is Dr. Siba Raychaudhari. Siba will be delivering a oration on novel therapies for cutaneous and systemic autoimmune diseases. And please allow me to say a few words about Siba also. I would have known him for over 30 years or maybe 40 years, almost 40 years. I met him in PGI Chandigarh for a while when I was there for a very, very brief period. Dr. Raychaudhari is professor of dermatology, medicine, and immunology at the University of California, Davis. And he is the chief of rheumatology and hematology at VA Medical Center, Sacramento, and the director of the psoriasis and psoriatic arthritis clinic there. He did his graduation in medicine from Calcutta and then post-graduation from PGI Chandigarh. And after that, he moved to United States and did his postdoctoral training at Stanford University. We hosted that delegation yesterday from the Stanford and had the opportunity of taking him also to introduce to the delegation. Later, he did the Diplomate of American Board of Internal Medicine and fellowship in the American College of Rheumatology. He is a leading dermatologist, rheumatologist, and immunologist in the United States who has primarily worked on T-cell cytokines, network elucidation, particularly TS17, TS22, TS9, and several other molecules which are responsible for understanding the pathogenetic mechanism in psoriasis. He also developed innovative animal model and PET-CT imaging modules for the autoimmune and inflammatory disorders. He has over 200 scientific publications of very high standard, and he is also the editor of Psoriasis and Psoriatic Arthritis, Pathophysiology, Therapeutic Intervention, and Complementary Medicine. So I invite Dr. Siba Raychaudhari for today's oration, and the floor is now open to Dr. Raychaudhari. Thank you.
want to move that one, this side, or that one? Okay, that's fine. And they just move this one, right, or this one. Okay, this one. Huh? No, no, it's in sure, sure. I will. Fine. It's a great pleasure to be here, and my special thanks to Dr. Kaushal Dharma for inviting me to give this oration, and I'm very thankful to Dr. Srinivas also. So, many memories comes when I come to All India Institute. I like sharing a story, and you have to bear with that. So in 1985, I get a telegram from All India Institute that I got selected to do MD in pathology. And then simultaneously, I got selected in the PGI Chandigarh for dermatology. And I had to make that decision in 4. Pathology was in my heart. Obviously, that's why I appeared for that. So I could not sleep for 4 days. But eventually, I did dermatology. But then later on, as Kaushal has moved, I have done a lot of pathology and immunopathology. I had spent good time with Dr. Bhutani. Dr. Bhutani was an international teacher. I read his book, I read his paper. At Stanford, he came several times as a visiting faculty. So I had a good opportunity to know him. And my talk is a tribute to Dr. Bhutani today. So I'm going to talk on novel therapies for cutaneous and systemic autoimmune diseases. So here you see the blue sky of California. We are fortunate that our sky is all the time blue. And in the middle, you see my research group. And on the right side, me and my wife, we are in our research lab. So I don't have any conflict in today's talk in respect to any association with any industry or any other way, any companies. Immune-mediated inflammatory diseases are clinically diverse group of chronic diseases that share common immunologic and pathologic features, and very common diseases which we see, such as psoriasis, atopic dermatitis, contact dermatitis, autoimmune bullous diseases, and other systemic autoimmune diseases are part of this. In Western world, it is among 5 to 7% of population suffers from autoimmune diseases. India is a huge population, so in India as well, it's a clinically challenging field. Now, one disease is the disease burden, and another, because of its chronicity, it affects the family, children, learning, education. So treatment of autoimmune diseases needs both. They need the medical support as well as the social support. Autoimmunity is an immune response directed against an antigen, and that antigen could be in vivo or ex vivo. In several diseases, one of our common diseases, psoriasis, we don't know the antigen yet. These are heterogeneous group of inflammatory, generally chronic disorders of unknown cause, and it affects multiple organs, and that makes clinically very challenging. Chronic disease with multiple organ involvement, and very basic fundamental mechanism. I'm telling it too simply. Maybe Dr. Talwar will think it is not that simple. So basically, the activated T lymphocytes are making the cytokines, and the antibodies are fixing the complements. These cytokines are complements at the bottom line for inflammation and for inflammatory diseases. So, in respect to the cause of inflammation and autoimmunity, they need a genetic predisposition or genetic background. As we know, HLA-C W6, am I right, is one of the common association for psoriasis, and it is mentioned about other HLA association. But a psoriasis patient, psoriasis can develop in a neonate. And I have reported a patient developing psoriasis in her 9th decade. So why it is happening? Why it is coming at a different time point? Because there are certain environmental factors, and then psoriasis is a good example for that too. That a person, 12 years boy or girl, does not have a psoriasis, all of a sudden and gets the streptococcal infection and developing gutted psoriasis. Similarly, a patient is getting lithium for depression or anti-malarial for infection, these are working as a toxin and developing psoriasis. And biomechanical forces, psoriasis is again a good example that the inflammation is localizing in the tendo Achilles at the site of biomechanical stress. So as mentioned in the arrow here, that, at certain point, there is no disease, and disease is mild, and then it is progressing to severe disease. So, we raised the question, can we identify this disease in a very early stage, or can we stress this kind of a inflammation happening in autoimmune diseases? And obviously we did it together, and then the lady who took a leading role in this is sitting in the front, my wife. So what we proposed, that we all know the PET-CT imaging identifies cancer, and the basic mechanism that we are using a radioactive glucose. The cancer cells are hypermetabolic, they will take more glucose, and more glucose they will take more radioactive agent, and then we can measure the radiation, and that's why we identify the cancer. So we propose that inflammatory cells are also hypermetabolic, so we should be able to identify inflammation and quantify inflammation by using PET-CT imaging. But then when we tried the PET-CT machine, it was showing very low level. So then we worked with the biophysics department, had to increase the resolution, and here you can see we used a collagen-induced arthritis model. In this mouse, we gave chicken collagen, and you can see here in the day 0 there is no inflammation. With time, then paw is getting swollen and red, and after treatment you can see the improvement. This is the clinical things in the mouse. Similarly, if we take the histopathology, you can see the inflammation is coming, and you can see the formation of pannus. Simultaneously, the PET signal, which is glowing here, you can see the PET signal is also increasing. And in this, you can see the clinical features and the histopathological features are correlating with the PET imaging or quantification of inflammation. And we can measure how much radiation is there. It's called SUV max. And we have now applied this to human. And here you can see in a psoriatic arthritis, unilateral sacroiliitis, and we can quantify, we can give a number. What's the amount of inflammation? You see the SUV max is 5.1. So in case of autoimmune diseases, what happens, the antigen is brought to the lymphoid organ by the antigen presenting cell, and then it is presented to the naive T cells, and there is a generation of the memory lymphocytes, memory in respect to that antigen. But then it has to cross the endothelial cell barrier, and then it has to go to the individual organs, and we call homing. So the T cells has to home in to the organs and make disease. Like in psoriasis, the pathologic T cells has to come and home in skin, in inflammatory bowel disease, in gut, in rheumatoid arthritis and other autoimmune arthritis in the joint, in ankylosing spondylitis in spine. So one thing is generation of the memory lymphocyte, and another thing is the migration to the interstitium, and that requires the cell has to adhere, and then under the chemotaxis, they has to migrate to the interstitium. And here, there is an addition molecule on the surface of the T cell, addition molecule on the surface of the endothelial cells, and then the under influence of cytokine, chemokine, or traditional histamine, they will come to the interstitium. And when they come to the interstitium, then the antigen presenting cell presents the antigen with the MHC to the T cell receptor, and this is the primary signal. But for the perpetuation of the activation, we need the co-stimulatory molecule. So that is CD28 and CD8086. And once they activated, they will create the cytokines, and that will cause the inflammation. So, we raised two very fundamental questions, and we did two proof of concept experiment. Is it happening in human? Is this pathway addition, migration, activation, cytokine secretion, and then inflammation? And again, we took help of psoriasis. Psoriasis develops at the site of injury. So by tape stripping, we induced injury in the skin, and then only 40% develops, Kevner. But anyway, whether the patient develops or not develop, we went on doing serial biopsy. You can see 1 week, 2 week, 3rd week, 4th week, and we stained the T cells with CD3 antibody. And you can see in the 1 week, only few cells in the dermis. In the 2nd week, there are more cells. On the 3rd week, these T cells are hitting the epidermis, and there is a proliferation of the epidermis, the classical feature of psoriasis. So this proves that in human, this pathway can be traced, and this is happening. Then the next experiment we did, that if so, can we target the T cells and develop T cell targeted therapy for autoimmune diseases, for the skin and systemic autoimmune diseases? And again, we did for psoriasis. And to do this, we had to do two novel things. One, we had to create an antibody against the T cell, and that we do with the Fujisawa. I already told you that the co-stimulatory molecule is required, so anti-CD28 antibody. And then we had to do other thing, that if we show this in animal, many a times what we see in animal, we cannot reproduce in human. So we had to create a humanized model. We had to give an animal model which is kind of humanized for that human disease. So here what we did, we took the same biopsy of the psoriasis plaque and transplant in an immunocompromised mouse called severe combined immune deficiency. It does not have T cell, does not have B cell, so it will not reject the psoriasis plaque. And then you can see after transplantation the classical features of psoriasis, proliferation, the retipeg formation of the epidermis, and diffuse CD3 infiltrate. We stained this tissue with CD3 antibody. And then after treating with CD28 antibody, you see the epidermis has thinned out, and most of these T cells are not there. So this, we did in late 1990s, but it took time to publish the paper. So based on this work and many other elegant work, the concept of targeting T cell and treating autoimmune diseases came, and now you all know that abatacept, the CTLA for IG, is available, already approved for various conditions, rheumatoid arthritis, psoriatic disease, juvenile RA, and work is going on in many other specific conditions. So then we can block the T cells, or we can block the T cells functionally, because ultimately there are various subsets of T cells, like Th2C T cells is very important for allergic disease, atopic dermatitis, which makes IL-4, IL-5. So can we make antibodies against IL-4, IL-5? Similarly, there is a T cell called Th17 cell, and that is very important for psoriasis. So we thought that, can we study that Th17 cells, and we are in the right time, in the right place. The Th17 cells just got discovered, but its clinical application was not known. So we got lucky. So what we did, we first stained psoriasis plaque and the synovial tissue with IL-17 antibody, and you can see that IL-17 antibody T cells are there. And then we did the functional aspect by the flow cytometry. And as you can see here, the CD4 positive from the pathologic T cells derived from the psoriatic synovium are enriched with IL-17. Then obviously we had to do further work what this IL-17 is doing to the pathology of psoriasis and psoriatic arthritis. You can see here that Th17 is acting, IL-23 is acting on Th17 and then making IL-17A, F and dimer, and then they are acting on the IL-17 receptor on these keratinocytes, and there it is inducing plaque formation. On synovial fibroblast, we showed that it induces proliferation and generation of several cytokines and makes the pannus formation. Similarly, we did the work on endothelial cells. Osteoclast work we did not do, but in psoriatic arthritis, activation of osteoclast will lead to the bone damage. So this path got dissected, and then after dissection, you can see how many drugs are now available targeting this pathway. We have 3 medications against IL-23, the P19 antibody. We have 1 medication against P14 antibody, and then obviously against IL-17A. Now we have against IL-17A and F bimekizumab, and then also we have a medicine against the IL-17 receptor. So with this background, to make it short, for autoimmune diseases, the cytokine therapy is now for 25 years, and various molecules we can target. Obviously, the first was anti-TNF, and we know its limitations, especially in India. It's a risk for tuberculosis because TNF alpha is required for the granuloma formation for TB, and anti-TNF breaks it. In addition, IL-17, IL-6, IL-1, and you can see various conditions are mentioned here, both systemic and cutaneous autoimmune diseases where these antibodies are currently used. In addition, we have specific antibody against T cell, my first slide, abatacept, and then against also the B cell, the rituximab, which is very heavily getting used in now pemphigus, pemphigoid, dermatomyositis, many dermatological conditions. But the limitation of this, because we are using for 25 years since the beginning of this biologic era, that after 2 to 3 years, we find that this antibody is not working, whether it is anti-TNF or anti-IL-17 or anti-IL-1. So we thought that what could be the problem? Obviously, one, possibly, it's an antibody making antibody against itself, and that's why it is losing its efficacy. But what we observed, we studied the pathological T cells collected from the synovium of rheumatoid arthritis and psoriatic arthritis and the effector memory T cells. We found that they not only make one kind of cytokine, like we know in psoriasis, psoriatic arthritis, IL-17 is important, but here you can see that in PSA, IL-17 is 14%, but in RA also they are there 5%. Similarly, you see the effector memory T cells are making multiple cytokines, not only one cytokine, and then our hypothesis is that probably the kinetics and dynamics of the cytokine is changing. And so at some point, in addition to antibody, other factor could be that other cytokines are getting produced, and that's why that antibody is not working. So how do we overcome that? So can we block multiple cytokines? And that's where the targeting the signaling proteins, the JAK-TETs kinase system can do. And here, very simply, I'm showing you that if we can block the intracellular signaling system, the JAK-STAT pathway, let us say if we can block JAK2, then we will be able to block interferon gamma, interferon alpha, IL-12, IL-23, and IL-6. So multiple cytokines can be blocked, and maybe that could be a good answer both into efficacy and the longevity of the efficacy of that drug. So you all know, I know in India, tofacitinib is getting used for several years and it is easily available, but various anti-JAK and pathway molecules are now available. Tofacitinib, ruxolitinib, baricitinib are already available. Upadacitinib is a TYK2 inhibitor. I will come to that, already available. And many others are now in development. So when it came, mainly this was used in systemic autoimmune diseases. So should it work in cutaneous autoimmune diseases also? So because of our field, the industry came to us, then we said, okay, let us see. So this is the thing. Before it came to the market, we proved that if we activate these T lymphocytes and then if we block with the tofacitinib, which is a pan-JAK inhibitor, we should be able to see its efficacy. And here you can see that with tofacitinib, we can block the JAK2, which is IL-23 induced, and STAT3. So tofacitinib likely to work in psoriatic arthritis. Similarly, this is the IL-22 induced keratinocyte proliferation. You see, as with IL-22 compared to the media, it is inducing proliferation, and when we are using the upadacitinib, the proliferation is significantly inhibiting. So these were kind of initial work, whether it should work in cutaneous diseases also. And this is the snapshot that first we got tofacitinib, then baricitinib, then upadacitinib. So tofacitinib is pan-JAK inhibitor, JAK1, JAK2, JAK3. Baricitinib is JAK1, JAK2. Upadacitinib is JAK1. And initially, as I mentioned, it was mostly for the systemic autoimmune diseases, but with time, we have established and we find more role of JAK inhibitors in various cutaneous autoimmune diseases. So currently, this is briefly I'm saying, as I mentioned, that JAK-STAT inhibitors are already approved for various indications and mostly combination. You can see most of the drugs both work for systemic and autoimmune diseases, but instead I will put more time in the next slide. So these are the dermatological indications where JAK-STAT inhibitor has been found to be very helpful. So here you can see that tofacitinib pan-JAK inhibitor has been found to be have clinical efficacy in psoriasis, psoriatic arthritis, atopic dermatitis, alopecia areata, vitiligo, lichen planus, hidradenitis suppurativa, and dermatomyositis. Now, all may not be approved by FDA. Various clinical trials, phase 2 and phase 3 trials are going on. And then ruxolitinib, this is a kind of a topical applications approved for atopic dermatitis and as well for vitiligo and alopecia areata. Baricitinib, JAK1 and JAK2 inhibitor, works in alopecia areata, atopic dermatitis, lichen planopilaris, and lupus. Upadacitinib, I think it is already available in India in a reasonable price. It works in psoriasis, but still not approved for psoriasis. It is approved for psoriatic arthritis. Efficacy of upadacitinib, the PASI 75 response is around 60%, whereas others, biologics and others have much higher efficacy. So probably that's the reason it did not get approved for psoriasis, but it does work. And then abrocitinib, the other JAK inhibitor, got atopic dermatitis. So a huge number of diseases are now getting treated by various kind of JAK inhibitors. Now I can skip these slides. But this is the issue. This is a major issue. The post-marketing study done on tofacitinib, which is a pan-JAK inhibitor, and compared with anti-TNF, and most of the patients were more than 50, and they found several risks with tofacitinib. This is specifically, again, I'm repeating, this study was with tofacitinib. There is a more risk for cancer, there is a more risk for cardiac diseases, coronary artery disease, there is more risk of thromboembolism. So what FDA did, that though it was only done in tofacitinib, they grouped all JAK others, the upadacitinib and baricitinib, and then they said that we have to be careful. We have to be careful, we have to screen these conditions, and two other recommendations they made. One, that first they have to fail anti-TNF, or anti-TNF is contraindicated. Because this study was with anti-TNF, anti-TNF has lesser side effect. And the second recommendation they made, if there is more than one cardiac risk, then we should not use JAK inhibitor. So, that is one of the important limitation. Now, I had talked with various dermatologists, because, I'm a part of the IIDVL also, that in India, some small studies are showing it may not be, that serious in Indian population. But I think, and that would be a good approach to do bigger study in Indian population and see whether similar risk is there, because in India, tofacitinib is available, and even, those who are below poverty line, they can afford it. So this study, I think possibly should be done in Indian population, both its risk in tuberculosis and risk of other conditions and mentioned. So this is the monitoring of JAK inhibitor. Like it is inducing infection, so we have to infection monitoring. We have to monitor infection, but more so, it needs clinical monitoring, as it's specifically mentioned here: thromboembolic event, malignancy, cardiac risk. In addition, routine test, CBC, LFT, creatinine should be done periodically. But another additional thing has to be done: the lipid studies. So the question, am I right? We get problem. How can we overcome this? So the next question, can you go beyond JAK inhibitor? And here you can see the first generation are inhibiting multiple JAKs. Specifically, you see tofacitinib, JAK1, JAK2, JAK3. So maybe it is inhibiting multiple JAKs. So multiple inhibiting JAK means inhibiting multiple cytokines, and maybe that's why we are getting so much side effects. So the next generation, upadacitinib, is already available, and it's a JAK1 inhibitor. Now, in the trials of upadacitinib, the cardiac risks and other risks were not found in the trials of upadacitinib, but they selected their patient in a different way. That could be another reason. In addition, there are other, you can see, TYK2 inhibitor also, and could those be have a less side effect? So that's our next thing. And as I was telling earlier, that deucravacitinib, which is already approved for TYK2. So here you see the critical cytokine for psoriatic disease, IL-23, am I right? Activates JAK2 as well as TYK2. Interferon alpha, very important cytokine for, now we have anti-interferon antibody for treatment of lupus, activates TYK2. So can this path be used for development new drugs? And already we have a new drug, deucravacitinib, approved for psoriasis with a good efficacy. PASI 75 is 75%. And the good news is that so far, these risks, thromboembolism, cardiac events, and hyperlipidemia, are not observed with TYK2. So this is a good progress, but post-marketing study will be done probably 1 or 2 years, we will know more. But initial signal is that we don't have risks with this. Now, several other TYK2 inhibitors are also going on in addition to deucravacitinib, brepocitinib, and roxacitinib. And you can see various conditions other than psoriasis are now getting evaluated: psoriatic arthritis, lupus, inflammatory bowel disease. In addition, dermatomyositis, sarcoidosis, graft versus host disease, and type 1 diabetes mellitus are also getting evaluated to see the efficacy of TYK2 inhibitor. Now, maybe I'm a little bit biased, but dermatologists are smart people. They have found out a different way to bypass the side effect of JAK inhibitors. So we have now several topical preparations, JAK inhibitor. As you can say, ruxolitinib is approved for atopic dermatitis and as well as for vitiligo. And these others as well are approved. And here, topical tofacitinib, our Indian dermatologists, they have developed this preparation. So this is another way, how can we treat patients with lesser side effects where the disease is not that severe by using these topical preparations. So this is our landscape in respect to treatment of autoimmune disease. 1975, gold and sulfasalazine available. Then we got methotrexate, and really methotrexate has changed the world, and we are still using heavily methotrexate. Then we got the anti-cytokine, the biologics, and small JAK inhibitors. But it's an ongoing process. Now we have one S1P receptor. So as I mentioned, the lymphocytes are getting activated in the lymph node, but they have to come out. It's called egration. So this molecule inhibits the egration and is likely to help many other autoimmune diseases. So, around 2000, when I joined Stanford University learning autoimmune disease, biologics were not that much available. They are either, gold was used heavily, and we dermatologists know gold can cause very bad dermatitis and as well as nephritis. So my professor asked him, the patient is there, in American culture, they're asking, did you give gold to this patient? I was thinking, giving gold to a patient? The patient should give me gold because I'm treating. But he meant that is the patient getting gold therapy. So, but now we are much beyond gold therapy with many other options. And you see, this advancement, I'm giving one example because inflammatory disease, is really complex disease. With this kind of therapies, now this is the recommendation. We can put the patient in remission. Similarly, for our psoriasis and psoriatic arthritis, with this kind of medications, we should be able to put the patient in remission. And in respect to psoriasis, especially, a new era is coming. Tissue resident memory T cells called TRM, and then IL-23 acts on this TRM. Initial studies are showing that in early psoriasis, if we can treat them with anti-IL-23, some studies are showing that they may be on remission after withdrawing the drug for 5 years. So definitely, good hope, good prospects are there, but as I have mentioned, we have to always consider the side effects. So, one thing, definitely I have tried my best to present what I know. And people like Dr. Talwar, stalwarts in immunology, are sitting here. Our great scholar Shankaracharya said, Prithibhyang putraste janani bahuba sant sarala param tesham madhe birala tarala hoham. That there are so many knowledgeable people are there. My knowledge is very limited, and you please ignore me. Similar way, Rabindranath Tagore said, Nitya kale utsavo tavo vishwero dipalika, ami shudu tar matir pradip jalao tahar shikha. The world is full with light, and your everyday celebration is with billion of stars. Can I be a little candle light? I'm thankful to the organization to give me this opportunity to put my simple studies which I have done, and sharing this with scholarly people sitting here is a great satisfaction to me. And again, I'm very thankful to Dr. Kaushal Verma for giving me this opportunity.
Thank you, sir, for a wonderful oration and sharing a lot of your own work and highlighting, various intricacies of this complex subject. May I now request our Director, Dr. Srinivas, and Dean Dr. Verma, to felicitate our orator. I would now call upon Dr. Vishal Gupta to propose a vote of thanks.
It's my privilege and honor to deliver this vote of thanks on behalf of the Department of Dermatology and Venereology. I'd like to express our grateful thanks to Professor Siba Raychaudhari for delivering this insightful and very informative oration. I'd also like to express my thanks to our director, Sir Professor M. Srinivas, our Dean Academics, Professor Kaushal K. Verma, who is also the head of the department, our Associate Dean, Professor Akesh Lodha, Madam Bhutani, and members of late Professor L.K., family members of late Professor L.K. Bhutani for their constant guidance and support in making this event possible. My thanks to all the faculty, delegates, residents who have joined us today and contributed to the success of this event through their participation. I might have missed out on names of some of people who I should be thankful to. Please accept my apologies and know that your contribution is deeply appreciated. Thank you so much. Thank you, everyone.
We've had an excellent morning filled with expert demonstrations, insights, and an informative oration. A big thank you to all the faculties, delegates, and the family of Dr. L.K. Bhutani, sir. I request the faculties of the previous sessions to now collect their mementos. Yes. Thank you, sir, for the wonderful oration, the informative oration, sir. I request now the faculties of the previous sessions to collect their mementos, and I request Dr. Somesh Gupta, sir, to kindly felicitate all the faculty. Uh, Now we can all disperse for lunch, which will happen in the hall behind the auditorium. Please reassemble by 1:45 for the afternoon sessions.